Hello, I'm Bill Mills, the President and COO of Best Upon Request. It's my pleasure to share with you this recording of myself, Chuck Haddix, the Best Upon Request VP of Client Services, and one of our valued clients, Dr. Stephen McGraw. Dr. McGraw is with the Independent Emergency Physicians Group and is Chair of Emergency Services for Ascension Providence Hospitals, Southfield, and Novi. Dr. McGraw shares candidly his perspective, his experiences, and his thoughts about concierge services in emergency departments. He will speak of Shayna and Fontella. Shayna and Fontella are full-time concierges with Best Upon Request, and they lead our team in the Southfield Emergency Department. You'll also hear him speak of Jennifer Carpenter. Jennifer is the Director of Emergency Services for both hospitals, and together they are dyad partners. They're dyad leaders for Southfield and Novi hospitals. We pick up in the conversation with Dr. McGraw speaking specifically about his perspective on our concierges. I hope you enjoy.
We have our own little mini experiment going on. If you think of the doctors and the nursing staff, by and large, are very similar at our Novi and Southfield campus. But as you recall, we moved the Best Request, Shayna and Fontella, over to Southfield only, because at the time, Southfield was really challenged by some of our volume, by some of the patient satisfaction. And what we noticed, and I will tell you, I think there's three things where it's really mattered the most. One, to me, is the comfort of the patient, which is primary, right? I mean, the patients have someone to talk to. And as a physician, I see them, your employees, reaching out to our patients, comforting them, being kind to them, asking if they need anything. I will often forget to eat myself, so I forget to order food for a patient. I mean, that's how distracted I can get. They remind me, they'll say, Dr. McGraw, the lady in 19 hasn't had anything to eat. She's been here 11 hours. And I'm thinking, oh my God, how did I forget that? Just because I forget to eat doesn't mean others should. And they're professional and they're kind. And that is a big help to the patients. Second, it's a big help to people like us who are providing the care, to have that person who can spend more time than I can spend, just sometimes listening to patients. We focus on the things they physically do. They get a blanket, they get water, they help them order food. They 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 act as a interactive liaison sometimes between the family and the patient. They get them a phone charger. Some of these little things are so gigantic when you're otherwise in a hospital, and literally a hospital tells you what you can eat, when you can eat, when you can go to the bathroom. It's one of the most uh, you know dehumanizing encounters people can have, is to be a patient, and they mitigate a lot of that. But I'll tell you, there's a third one. So the patients and then the staff like me. But there's a third group that I don't think we really recognize their benefit enough for. And that's how all the other ancillary staff, and I'm talking about the housekeepers, the EMS providers that are in and out of our department, they do little things that I see that make everything smoother. And just as an example, the EVS people, um, they have to clean these rooms, and they have to do it a lot. We turn these rooms over fast, and so they're exhausted. But they don't have time to go get a pillow, because sometimes it's like a Leonard Nimoy in search of mission in our department. All the pillows get used, so they'll find a pillow and they'll put a pillowcase on it. Now, okay, so you say, well, that's just one little task. It didn't really impact anybody. Oh, yes, it did impact somebody. It impacted the EVS worker who otherwise would have been waiting, hearing overhead pages. We need EVS to room 13, 17, 21, and 26, bed turnover. I mean, they've now just got 4 new rooms to clean top to bottom. And it's like, it's cleaning blood off the floor. It's cleaning the bed rails, the mattresses, the sink. They have to go in like a whirlwind and literally do everything they can. And they do this for like 12 hours at a time. It's exhaustive work. Then the bathroom and such needs to be cleaned. And we need EVS out at triage with a mop. Someone vomited all over the floor. I mean, they have this incredibly complicated job where they always feel like they're always behind. like they're never going to get their waiting room. My waiting room, I can clean out with my partners. Their waiting room never ends because there's always rooms to turn over. So, and I've watched your folks do not wait to be asked. Shayna and Fontella help those people. The EMS guys are about to leave, and they need to put a new sheet on their cart for the next patient they're going to go get. And they're running around. There's no sheets where they know to look. And so Fontella says, oh, I can go get you a sheet. Don't worry, I'll be right back. Now, your contract doesn't say, line item 19, and provide bed linen turnover to Southfield Fire and EMS personnel. They just do it. They do it because they're holistic in what they view as the team that they're here to help. And I know that's part of what you teach them, but I'm a leader who has a lot of folks, and I try to give messages like that. And I know it only gets to about 80% of my partners, 85%. There are some, unfortunately, in every industry who will say, look, these are my defined responsibilities, and I'll do all of them. But I'm not going to look to go find other things to do. There's a little thing that you would never, our food service workers, when they bring a tray of food to one of our patients being held, once you've eaten, you kind of want that tray out of your room. Your room is small. Just the debris of the cups and the spoon and the napkin and the empty coffee cup and the little creamer. You don't really want to see that anymore. You've had your chance to get nourished. Now you just want to put your feet back. And so I've seen patients, and there's not a lot of places to put a tray down. It's on your bedside tray. There isn't another place to put it. You're in a gown. You don't want to walk out in the middle of the emergency room, even though it's not her responsibility. Shayna will see that, take the tray and put it in the dirty tray rack. She'll go and ask, then she comes back and asks the patients, are your feet warm? It's kind of, the air conditioning's on. It's kind of cool. No, I didn't want to ask anyone. And then she goes and finds slippers or a blanket to wrap their feet in. I'm very observant about what goes on in my department. And I will tell you, they help everybody. They help the staff, the nurses and I, and my partners. They help the patients first and foremost. They act as an intermediary between all those highly matrixed points of discussion and contact. But then they go above and beyond and make sure that others are treated like a guest in my department. EMS providers, EVS workers, even something as simple as the pizza. I ordered pizza when I worked midnights last weekend, and the pizza guy was bringing the pizzas in, and they went over and held the door for him to get him into our nursing lounge. Nobody asks them to do that, but they treat everybody great. And now on a data side, our numbers in Southfield have, despite all the chaos, have either held their own or slipped, a point or two on that loyalty score. Well, if you look around Ascension, they've slipped a lot more than that, including our own sister hospital in Novi, where they're now consistently below Southfield. And that hasn't been like that for years. I don't think it's the sole reason, but I think there's a genuine part of that delta that has become, to me, evident that they don't have best upon request. And I think it's just it's a little thing, but for some of our nurses, they will go and find Shayna and Fontella and ask for help. They look at them as a resource. And I wish we had that at Novi. My goal, if you will, is to get you guys to be asked with my administration to staff Novi like you do Southfield. I think there's a benefit to it. And it's funny, of the two campuses, the Novi patient has much less patients with inconvenience. They don't stay at the Holiday Inn. The people at Novi generally stay at the Four Seasons or the Ritz-Carlton, and they view their frame of reference for what is good customer service is ratcheted, higher than the patients that I typically take care of in a working class town like Southfield and Detroit. They're sometimes harder to please. They're often easier in some ways to take care of because they know their own medical history so well. They have a lot of insight. They read before they come in. So I have partners that prefer to work in Novi, and I get that. I'm fine with that. I can work in either campus just as well. But I do know that some of the slippage from our net loyalty score, which was leading the state in Novi until the last probably 8 or 12 months, really reflected kind of the niceness of the department, the newness of the campus, the fact that there were always beds we could admit people to. We really got through the pandemic pretty reasonably well at the beginning. But especially in the last 2 months, we've been challenged with this backlog of medical care and surgical care. Our patients are not happy. The ER is always filled with admitted patients. And even though we don't think of it, Best by Request has some of its most impactful benefit, I think, to when patients are just waiting for a bed. I mean, they're smart enough out there to know they're an admitted inpatient, stuck in an emergency room, sometimes on a wall, with very little, if any, privacy. Or if they're in a room in my department, it's still not ideal. It's not like a room they're going to have. They know what they're going to get upstairs, and they're not getting it in my emergency room. Upstairs, they're going to get a private bathroom, a private shower in their room. They're going to have a large sort of bench console for their family members to stretch out and go to sleep. In my emergency room in Novi, it is Guantanamo Bay. It looks all right. I mean, it's okay, but it's Spartan beyond belief. There is a sink in the room. There's no room for their family member other than a little chair to sit in. It is not designed for people to spend 12 to 24 hours or more waiting for an inpatient bed. And I actually believe, and I'll just say this because I'm not offering to let it be the case, but if I took Shayna and Fontella, moved them both to Novi, I genuinely believe in very short order, the scores would go up in Novi and the scores would go down in Southfield.
Wow.
There's more than one variable here. We don't have the number of holds in Southfield that they do in Novi, so that probably impacts the numbers. And I'm not even saying that Novi would then be higher than Southfield on that loyalty score automatically. I think there's just too much discontent with being held for so long and waiting in the lobby to be seen. But I think it would narrow the gap.
Dr. McGraw, your comments are so important to us and so meaningful. We often get asked when we're, having discussions with an organization about an engagement like this, and invariably, there's either a physician leader in the group or the questions follow shortly thereafter. But there's always curiosity from physician leaders. What can we expect? Are they going to get in the way? And then on some occasions, we've had physician leaders say, I like the idea, but is your staff going to be willing to look me in the eye and say, hey, you need to go back into room 19 because you didn't leave such a good feeling? And so we get just a lot of questions from physicians. I wonder if you could speak to that a little bit, just in terms of how other physicians on your team feel about the service, and/or what apprehensions were there at first, and have those been alleviated since we've been partnering with you?
Yeah, I didn't hear a lot of hesitation. I heard maybe a little, I don't think it'll matter. I don't think it'll make any difference. I think there was a lack of understanding of what they were going to do. Now, and I also have to say, if the majority of your staff are like Fontella and Shayna, you're incredible. I think I am getting a particularly wonderful group, but they should really be, you should have people look at how they work, and they could learn a lot, because they impressed me with their innovative kind of outlook. No, my partners would tell you right now, they can't recall a time when they get in the way. They had to learn. I had to reassure them, more than once, that you can come to us, tell us when a patient's not happy, or they misunderstood us, or they don't know what's going on. And there's still, I don't think they leap at it. I think they start with the nursing staff. Hey, she was told by McGraw that something's going to happen, but she didn't understand what he said. Could you go explain it? And then Ahmed or Faith or Shannon or somebody else would go in and, sort of intervene for me. I know this happens because I only get it when that wasn't good enough. They've already, and the nurses are very protective of my partners and I. I mean, they really do they know that we're we're running around, and so they have a more of a established relationship in many ways with the patient and the family. So they'll intervene first. It's when they can't be successful that they say, hey, I talked to this lady. She still doesn't understand X, Y, or Z. Then I go back. But I often say, gosh, I wish I had known this when it first started rearing its head 20 minutes ago. I would have saved everyone a lot of work. But I
Mm.
think some of the protectiveness that our nursing staff has of my partners and I is reflected that they don't come to us immediately right away. Though they do sometimes. It's just not the majority. But and I think that's okay. They don't have to come to us with every question. But I also think they could come to us a little bit more. And it's just their own, they're incredibly respectful. You probably know that. I mean, they see I'm busy, they see I'm dictating, I'm talking with somebody on the phone or something. They just wait. They just stand, 8, 9, 10 feet away, just waiting for me. They won't interrupt. They just patiently look, and then I see over my shoulder. I go, Fontella, what's going on? Oh, no big deal. When you get a chance, no emergency. Um, this patient's family member is here, and she had 2 questions the patient didn't know about how to answer. And I'll go, gosh, you could have stopped me at any time. Oh no, I saw you were busy. So they're so just so I think the notion that they didn't that they don't want to interrupt us or interfere with us, they hold to that very dearly, and they'll err on the side of waiting themselves or having a nurse intervene. But my partners and I never feel like we're getting squeezed by them ever. It just doesn't happen.
Dr. McGraw, we talk a lot about culture at Best Upon Request. Also, I appreciated all the things you said and just the leadership you provide with your group. Could you tell us, just for the record, a little bit about your provider group and your role there?
Yeah, well, I've been the chairman of the department for oh man, since 2012, I think. Um, but my partners and I are all owner employees of the company. So, I'm nominally the chairman of the department, but we expect every physician to be a leader, a clinical leader, a team leader, and open to questions, open to new ideas, um, and to treat when a colleague comes into our department. If a surgeon has a patient that we're asking them to see, or our trauma colleagues or our cardiologists come in to take someone to the cath lab emergently, our goal is to treat them like a guest in our office. And meaning, like, we thank them for coming in. We ask because we're the home team, we know where the chart is, we know where the patient is, we know where they need some dressing supplies, to dress a wound or look at a wound that I've sort of addressed and then done what I can, and then now it's got a new dressing on it, but someone's got to take it off and give their expert opinion. So when they come in, we want to treat them like they're a guest in our office, because that's what they are. Yes, they're performing a required service. Yes, they have to be on call, and this is part of their job. But I know that if I went to one of my surgeon's office, they would treat me as a guest, right? They would treat me as a colleague, a valued member of sort of this partnership we have. I want all of my owner employee partners to view colleagues that way. And that includes EMS providers. That includes your folks, our nursing staff. This is our office. We don't pay for it, and we didn't build it. And the bricks and mortar don't belong to us, but that's our office. And I won't let people be treated disrespectfully. I won't let colleagues dread coming to see us and help us. Just the opposite. I want them to say, hey, the ER got a patient, I got to go, get a food bolus stuck out of their esophagus. When the gastroenterologist arrives, we've disrupted their day with this need to have the food bolus pushed into the stomach. I want it to where they can come in, the patient's ready to go to the endoscopy lab. It's quick. They push it in the stomach. They get home or back to their own job that, is regularly scheduled. Make it as painless as we can for them. It's going to be painful. There's going to be disruption and things they have to do. But your staff, your best, and I say them individually, Shana, Fontella, et cetera, but the notion of the culture you've created is to treat people like a guest. I've seen it I know that's how I believe. My partners believe that. And no, not everybody's going to be the same, and not everyone's going to do it as well. But the fact that that is something you're trying to do, your folks may be particularly good at it. Some of my partners and I maybe not as good, but we're trying. That is the thing that will make us stand out and patients feel, and some days the worst day of their life. We're just trying to mitigate some of that worstness and make it better.
Dr. McGraw, when you were talking about the culture, and Chuck, I think, touched on it. We focus a lot on culture. What you were referring to is something we spend a lot of time on, and that is if you create an environment where people feel safe, if you create an environment where people trust leadership, you're going to have a high integrity culture. And so that's what we call our culture is high integrity. And we spend a lot of time on a philosophy that we call things happen and people make mistakes. In other words, every time we hire someone into our company, we tell them that our expectation is that they're going to make mistakes. And so here's what you do when you make a mistake. You invite someone, you call your director, you call a peer, you call someone at the corporate office, but call and ask for help. We're here to help you. We want to make you better. And we can't help people be better if they're not willing to be vulnerable and share their mistakes, their questions, their concerns. And so it's this idea that if people feel safe, then they will surrender their mistakes. They will make them known and they will share what's going wrong or what they didn't do very well at for the sake of getting an improved idea, better coaching, a new learning, and then applying that going forward. So for us, what you just described is really integrity. It's the culture of honesty and integrity where people are quick to say, "Hey, I made a mistake. I need some help."
No, and Bill, that's a great point, but I'll tell you, that's exactly what we have to do in medicine. We we are humans. It's an uncertain, sometimes we're bereft with data. The patient's unconscious, can't even tell us what their medical problems are. So we're often, kind of fixing things while we're even sorting out what's wrong. It and it's not a lot of medical practices that have sort of that exigency present on a regular basis, but we do. So of all the areas in the emergency department, especially, but truly in the hospital, when you're dealing with an environment with that much uncertainty and sort of propensity for error, misunderstanding, judgment error, you have to be humble and know that I'm trying all this and it's not getting better. And emergency physicians and nurses are particularly good at saying, this was my initial thought and it's not getting any better. So we got to go in a different direction here. You're right. You have to have some humility, some self-awareness, and integrity. All those are true. But the environment itself, the culture we create, if it's more than just ourselves, that multiplies the benefit to the patient. And that's why I think you're correct in saying that it is a culture of honesty and transparency and, yes, safety. That vulnerability that you have to admit something didn't go right and then recover from it is something near and dear to me. Just as an example, I've had patients who were really enraged for whatever, something didn't go right, they didn't understand me or whatever. And I can feel my own anger, welling up. I just like I'm on a basketball court. I just make the tee with my hands and let's go timeout. You're really, really angry and I'm not making you any better and I'm not making it better for myself. I think I'm just steering us right into a really unfortunate event. I'm going to go take about 4 or 5 minutes, collect what I need to understand, and I want you to take a breath, and then I'm going to come back and we're going to start over. But it's being the home team. I can do that. I can tell them I'm going to be back in 4 or 5 minutes, but I need to learn. I need to learn a little bit, calm myself down, let you take a breath, and when I come back, my parting words are always the following: you and I really actually want the same thing. You want your mom to get good care, and I want to make sure we're providing it. And then I come back and they've thought about those last words. And no matter what has transpired, it's like I've asked them for a second chance. And that's usually all I have to do. It stuns people when I do that. I mean, it's a little trick I learned a long time ago from a physician. But it's like they're not expecting that. They're expecting the fight to, reach some crescendo. And I just totally, like, lick my fingers and, put them together on the fuse, and the fuse goes out. So then I come back, they're gathered themselves, I've gathered themselves. And those last words I say, that we're on the same side, even though it doesn't feel like it. Then they're like, okay. Nurses actually really like it when I do that, because a lot of times the unwritten and unspoken signal to the patient is, we're going to try this again and do it better. I'm going to try and be better. I want you to try to be better. And we're not here to fight. We're here to both achieve the same thing. While it's a little technique, it reflects the kind of culture that my partners and I really want. We want things de-escalated. We don't want people's hurt feelings, especially in an environment where things are so charged. But the more mundane thing is the more common one, truly. It's the person with abdominal pain. And we know they have abdominal pain because they have diverticulitis, and they're going to have to be admitted to the hospital. They're probably going to have surgery with a big abscess. I don't, with all my other distractions, don't go back enough and ask them if their pain is being well controlled. But if Fontella is talking with them and sees them wincing, she'll say, do you want me to ask the nurses if you need more pain medicine? They invariably say, boy, that would be great. That is such an impactful thing, because she'll go and find Faith and say, she was wondering if it's time for her new medicine. The antibiotics are helping, but they don't help enough. Can she get more medicine? You've just saved the patient the effort, because a lot of them don't want to turn their call light on and ask for stuff. They see how crazy it is. They actually feel badly for us sometimes. It runs the whole gamut. Some patients think no one else is in the whole department, and others are so overcome by how many people there are to help that they don't want to bother us. They're like, you took care of me. I'm fine now. I'll just wait here for, suffer for the next 12 hours. We see the whole spectrum of human response to that environment. But one of the neutralizing factors is when, Shayna will go in and ask somebody, what's going on? Do you need anything? And I don't know if you guys know this, but they make a list. They literally do rounds around the department. They don't miss anybody. It's very deliberate, very systematic. And whatever time they need to spend, they take it. I don't know how much of that is the training they got. I imagine quite a bit, but also it's what their willingness and compassion for people then lends them to do and leads them to do. They need some direction, I think, early on, but now they're just a fixture. I think they help the patient primarily, our staff second, and all the ancillary visitors to our apartment next. That's a big deal. That's a really big deal. I wouldn't want the relationship in any way to change or go. I want it to grow to my Novi campus, as I've said, but I think they help us be a better department.
Dr. McGraw, you said several things that really resonate, and we often talk about, when we're considering an engagement, we sometimes realize that, okay, this is going to be very challenging because the leadership may or may not be, or in that case, may not be ready for a resource such as this. When you describe your leadership style, when you describe the environment and the culture you've tried to create, both from a physician perspective as well as the nursing team and the respect between you, I think one of the reasons, if I can just be very transparent, one of the reasons you're experiencing success in our service is because of the environment that you've created. It works to have a resource like a highly trained, highly emotionally intelligent, compassionate and empathetic person come in alongside. And you're talking about a couple of people working alongside a couple hundred people. And so we're very aware of what our role is. And yes, we have training and coaching, and we have a process that we teach our concierges. But at the end of the day, it won't work if the culture isn't right. And we've had engagements where the culture wasn't strong enough to support a concierge being effective. And so I just want to encourage you that you're doing a lot of things very, very well, very, very effectively, and you've created an environment where other people can be successful in helping you achieve optimum results.
Well, that's very kind of you, Bill. Thank you. It's certainly not. It wasn't. It's not my idea. It's the culture of my company, and it's not me individually. I mean, I really expect, um, whether I'm physically there or not, I anticipate and expect all of my partners to behave in a way consistent with our core values. We have 6 core values in my company. The first one is integrity. The second is compassion. The third is professionalism. The fourth is patient satisfaction. The fifth is professional excellence. And the last one is honesty. But I think that notion of we are more than a collection of physicians who have a lot of training. We're also people. And we work in an intense environment where the most important thing most days is not what I know. To be honest with you, the most important thing I can impact is how I make somebody feel. I know for a fact I could take an internist for a lot of my patients and they could manage the medicine pretty capably, maybe 90% of the time. There's 10% that are just disasters, and really emergency physicians are what you need. But 90% of our patients with abdominal pain can be managed just as well by a surgeon. And 90% of my internal medicine patients could be managed by an internist. You don't have to have my training. What you do, and I think is critically important as a physician, is the ability to do all those things, no matter what the patient's problem is, and most importantly, make people feel differently. We have such a narrow window to gain their trust. My family medicine colleagues know people for 20 years. I might know them for 20 minutes. And at the end of that 20-minute encounter, if the patient doesn't believe what I'm about to ask be done is in their best interest, and they have to believe it, not suspect it or hope for it. They have to believe that I'm doing what I can to make the situation better, that I'm not holding things back or doing things unnecessarily. They have to believe the way I describe it is true. That's a lot to try to accomplish in 20 minutes. You can't do that if you don't have a set of values to operate from. You got a lot to do in 20 minutes. You can't waste it by not having a foundation where you're doing everything you can to make that belief possible. Because the truth is, if I make a bunch of medical mistakes, people will forgive it and they'll understand it. They know they don't expect me to be, omnipotent and never wrong. They know we're human, and they'll forgive it easily if they know that your heart was in the right place. You made them feel like they could trust you. But the truth is also true the other way. If you don't impart that belief, if they don't understand that's where, that you didn't make them feel that you were, in on helping them, that it was just a service, like you were just, I always come back here at the rental car counter. If that's how you make people feel, then when you make the inevitable mistake, they won't be as forgiving, because the truth is, this isn't transactional purely. If it is, then I'm in the wrong business. This is too important a human endeavor, and there's too much risk to be, just plainly transactional. What they need to know is, people I love and care about have been patients too. I've been a patient, and it's a whole lot easier to be on the other side of that bed than in it. If we, as a group, make that, and we hope to do that after, I think we've been in around now for 24 years. If we're successful in making that how we think and how we practice, and truly partner with the nursing staff to do the same, and it doesn't feel transactional, patients respond to it. The other thing is, what you guys do is not easy. You come in as a a teammate, and you got to sort of work your way into the flow of the department that isn't obtrusive, but also is still effective. You got to walk kind of I'm amazed at how quickly they integrated themselves to the nursing staff and gained the trust of our nurses. But Fantal and Shayna had a kind of a weird line to walk. Like, what are you really doing here? We don't know who you are. They were very good at explaining at the very beginning. I don't think initially Fontella knew that we were going to ask her to go to the waiting room and check on people, but we did, and she does it. To tell people they haven't been forgotten is such a gigantic thing. When they're waiting, they don't know if they're going to wait another 10 minutes or another hour or 3 hours. There isn't, there isn't like, there isn't the thing they have at the Secretary of State's where you can see, oh, I'm number, or at the, at the deli counter, I'm number, 14, and they're serving number 7. So, okay, well, they're getting to me. There's no way to know in an emergency room because so many things, there's so many points of entry. They can't see what ambulances are bringing us. So nobody knows. But if they hear from someone who comes out and says, gosh, we're so sorry you're waiting. I'm gonna relay all your, how unhappy you are to the doctors and nurses. But in the meantime, can I get you a cup of coffee? Can I get your family member, a thing of juice? Your child looks really bored. We have some crayons and a coloring book. I'll bring those out. Just to know they haven't been forgotten. They're not some, task waiting indeterminately is huge. And she did that. And I think at first she was like, I don't know what I'm doing out here, but she figured it out very quickly. And that helped a lot. I think it helped us a lot. When the patient finally does come back, they're not all angry. If you spend the first of that 20-minute encounter, if I spend 10 minutes telling them how sorry I am for how angry they are, that's a big time crunch to try to learn what I have to take good care of them. I got to get by the anger to find out, okay, is this a urinary tract infection? Is it appendicitis? Do they have a bowel obstruction? I'm doing all those kind of calculations in my head. Well, if I have to spend a lot of time getting them to trust me because they're so angry, it just slows everything down. It makes my job much harder. The same with the nursing staff. They come back less angry because they don't think they've been forgotten. Now it's easier to put the IV in. It's easier to draw their blood and get over to X-ray. It just makes everything easier.
I'm sorry.
Oh, go
Your
ahead.
ability to focus in those moments is critical. And if you encounter someone who's angry, whether it's the patient or a family member, it could completely knock you off your game. And so I
Yeah.
can imagine if you're a physician, you need a clear head. You're diagnosing people in a matter of minutes, perhaps a lifetime of accumulated effects that they're walking in with and presenting, and you've got to figure all that out. The last thing you need is to have to diffuse a difficult situation before you can even get started. So um, I have just so much respect for what you do and how you do it. And we're honored to be able to come alongside you and help prevent some of those situations when possible.
I think one of the things I'm continuing to learn, and going back a minute ago to what Bill was saying, just with your leadership, with your provider team, but then also someone like Jennifer Carpenter, who's the director for the program there, and helping our team to, take barriers down and set them up for success. And then you guys are focused in the emergency department from crisis to crisis to crisis to crisis to crisis, focusing on medical needs and clinical needs. And I think the pride that we have is being able to come in with focused empathy and look for those non-medical needs, those non-clinical ways that we can, be hospitable, provide customer service, create that patient experience. And so, but it takes all those pieces working together successfully. That's what I'm continuing to learn.
Well, thank you, Chuck. And it is true. And your folks brought that. I mean, there's something about trusting others, but it also really helps when someone comes in ready to be trusting. And they did. They put a lot of faith in Jennifer and the nurses' hands to say, we're here to help. And we trust that you're going to give us direction on how to do that. That's not a little thing. That helped. They went over the 50-yard line, then reached out.
And like you said, from the time a patient or family is coming in, to registration, to triage, to, the waiting time in the lobby or in the room, we learn together how to spend those. It could be 30 minutes, it could be 15 hours, and we're learning together how to invest ourselves in to create that great patient experience together.
Well, I think the other people besides Jennifer, there are clinical nurses in my department who have gone from, I don't even know why they're here, to I hope they're here today. They've completely figured out how nice it is to their own practice that the patient has a resource like that.
Mm.
I think, especially younger nurses would say, "Well, isn't that what I'm here for?" And of course, that's true. That is absolute. That's why you're here. But the thing that your folks can help us do is to actually do all the things we're supposed to try to do ourselves, but to do them easier and more quickly. Our nursing folks have so many tasks, and a lot of them are, just technical administration of medicine, taking vital signs, doing procedures, and so they have to do all that, and all those are minutes. They're not, talking to the daughter from California who's terrified that her mom is in the hospital again, and just something as simple as taking down the phone number and say to me or to one of the nurses, "Hey, this is the daughter's number in California. She's just completely alarmed and just wants an update." You know, little things like that. Um, that and someone will get with you, or telling the son in the room who just showed up. Mom's been in the department now for 4 hours and doesn't understand anything that's happened. Oh, I see that you're here. I'm going to make sure the nurses know. Come and fill you in. They're
Mm.
taking care of a really sick person next door, but as soon as they get the baby some IV fluid, then I'm going to have them come and talk to you. Now everything is like toned down. All the anxiety that the situation would otherwise call for is suddenly manageable. You know.
Dr. McGraw, what you just described, we've been using a slide for certainly in our sales process, but we use it in our training for concierges. We've used it for years, and it's an image of someone, a medical professional who has this patient care orientation. So it's like a photograph of a patient, I'm sorry, a professional serving a patient, kind of having a conversation with them. And on the other side of the spectrum is a picture of that same person doing paperwork. And so the caption is, "I want to, but," and so there's space in between this ideal situation where I'm constantly providing comfort and answering questions and listening and serving, up to the reality that there's a lot to do with this role beyond that. And so we use that to illustrate it's that space in between that as concierges, we can step in and fill the gap. And in some cases, it's helping out, as you said, environmental services. In other cases, it's providing a degree of care and comfort that the staff is just simply too busy to provide. And that care and comfort is sometimes listening, sometimes it's a warm blanket, or it's something in between. But I think our role and hopefully what you've experienced from our team is, number one, as you said, they're the right people. We have amazing people. It never ceases to amaze me how fortunate we are to have the team members that we have. But we do train on understanding what are those gaps? What are the opportunities for us to step in and innovate? What are the opportunities for us to be a level of empathy that this family wouldn't have the opportunity to experience if we weren't there? And what are the things we can do to fill in the gaps? What is the staff struggling with? What are the physicians struggling with in terms of getting caught up or maybe responding to a patient family in a timely manner? And so we want to be a gauge for that. We want to be an informant. We want to be someone who's advocating for the patient, for the family, all in the spirit of elevating that overall experience. I just want to thank you so much for taking the time to share. And we just appreciate you, appreciate Jennifer, and appreciate being able to be in a partner, your partner at Ascension. And so thank you for that. Any final thoughts from you?
Well, I love the notion of that slide. I think that's absolutely true. If the EMR has made us safer and made no more hand writing misunderstandings and stuff, that's good. And things are time stamped better now. I get all that, but the EMR also pulls physicians to some extent, but especially nurses, away from the bedside. So you're right. There's a giant unmet need that your folks help to fill, and I'm so thankful you see that as a big part of how you can help us be successful. Your people are special, but I think groups tend to take on the characteristics of their leadership and their training. So that really reflects well on by your company and the philosophy that you hold dear, and I'm thankful for that. I guess my only parting wish is just to know that I'm grateful. I know Jennifer's grateful too. We would really, both of us are working on our system to try to expand you back to Novi. It is true that we're, I think, better able to meet our patients' needs with your folks around than not. And I really want to thank you for that, but also recognize that we need more of you and more of your efforts and not less.